I think we'll get started. We're just at 12 o'clock and I want to be courteous and have enough time for discussion. I'm really excited. It's Alice Fornari, who runs the journal clubs, and I have a really exciting journal club, what I think is a hot topic in our health system today about global health. And we actually have the director, Eric Peña. Did I say Peña? Peña, yeah. I'm sorry. Here, the director of our new Center for Global Health, and really exciting that Northwell has agreed to centralize the process of global health and really strengthen it through that centralized process and give it really a lot of good meat so that programs are able to really be successful in the global health arena versus a more scattered, dispersed approach that's been happening, you know, over a number of years here. So I think this is great that he could speak. We have Nicholas McCarter, who is going to be our Northwell Health discussant. He's no longer, Nick, you have under there ethics fellow, but I think you're actually an ethicist at this point and is part of the ethics team, as well as faculty in the Health Information Technology program. If I'm not correct, he's also director of that program. And he's also involved heavily in the professionalism and ethics curriculum at the medical school. So I think he's a great candidate to be a discussant. He's going for a doctorate in public health as well.
Yes,
and,
correct.
Did I get all that right, Nick? Yes.
Correct. The fellow part of that is no longer accurate. It is now just ethicist. It's okay.
He's an ethicist now. And Wendy Herman is our trusted medical librarian who I couldn't live without. She is my right-hand person in everything I do, I think. And she's here today as our medical librarian for the Journal Club and always adds insight. So I think we're going to get started with Eric with the slide deck. So if you don't have the slide deck up, we'll be talking through the slides, but obviously if you have the slide deck, it makes it easier. We will send the slide deck post-session. And let's go to the first slide because it has a little bit of housekeeping.
Sure.
If we have not done that housekeeping already.
Oops, sorry.
Yeah, so I just want to say, if you don't want to have the video, of course you don't. I have it on now so you could see Eric and I for people who want to do that. Once again, the audio is through the computer or phone. And if you want to be known, you need to, of course, do an audio pin. And we will be doing it muted. And if you wish to be unmuted, you could request through the chat. So there's two ways I just want to mention that are circled here in red to be able to talk to us. One is the chat feature, and the other is through the messaging on the right. So they're circled in red on the screen. And either way, we will be monitoring those for questions or comments. And the webinar will be recorded and it's uploaded to my faculty development site like all the others at the School of Medicine, and anybody who wants to get back to the information can. So I think that's all my housekeeping. I'm going to let Eric take the show.
All right, thank you, Alice. And good afternoon to everyone. Thank you for joining. I'm very excited to be speaking with you today. My name is Eric Peña. I'm the director for the Center of Global Health at Northwell. I've been in this role for about 18 months. It's been a rapidly changing and evolving science here at Northwell. And so I'm excited to talk a little bit about that at the end, about kind of what our vision is for global health moving forward. And I think that the article that we're going to be reviewing and discussing along with Nick really kind of sets a little bit of a theoretical and scientific perspective on it, because we're going to be talking about kind of ethics and how to go about these trips responsibly. So I hope you all enjoyed reading the article and the supplemental article if you got a chance to do it, but I'm excited to take you through this.
Wait, I'm sorry, I have to get rid of this.
There you go. All right, technical difficulties aside, thank you for joining us. I'll just start by saying that unfortunately I have no conflicts of interest that are financial in giving this lecture. I'd love to have some, so message me privately, and I'd love to start accumulating conflicts of interest. So I wanted to we're going to unmute in a second, but I wanted to just ask people to volunteer just as a way of getting kind of the juices flowing in the spirit of participation through this journal club, to talk about anyone's experience in global health. Yeah, I did. Yeah, global health in your prior education. Anyone who's had any type of global health experience, and if anyone had a brief global health story that they wanted to share. I think I'm going to unmute everyone. If there's someone that has a lot of background noise after I unmute, hopefully you'll recognize that the background's pretty disturbed, and you'll mute yourselves. All right, so unmute now and feel free to chime in. And please announce yourself before you chime in.
Hi, my name is Mary. I'm a fourth-year medical student at Hofstra. Hello, everybody. I actually found this topic really interesting. I myself am one of these short-term medical degrees. Sorry, are you guys hearing me well? I just want to.
Hearing you well right now.
Yep.
Okay, wonderful.
Merari.
Okay. During college, I went on one of these medical brigades, and I actually had a lot of ethical, or I guess moral reservations on going these brigades for a number of years. And it wasn't until I found an organization that I thought would be able to meet the goals of a community in a more sustainable way. And that's how I decided to go on one of these trips. So it's interesting to see that there's very little scientific evidence behind the efficacy of these groups. And even in those organizations, perhaps there isn't as much research done to make it to really prove their point that they are making the difference that they say that they're making. So, yeah, I think one of the big things that I look for in these organizations to see whether there is that sustainable component, and I'd really like to see evidence in the future to see what defines sustainable.
Yeah, interesting comment. Thank you. It's certainly, we'll talk more about the article as we move forward, but it's certainly, I think there's a lot of opportunity for an evidence base in this field. So absolutely. And thank you for sharing. I appreciate it. It's always tough being first.
And I want to mention, as a medical student, you're going to have lots of opportunity to produce evidence. So we'll count on you a little bit if you want to continue your pursuit in this area, especially your work with children, because I'm pretty sure you're going into pediatrics, right?
Yes, I am.
Right. I just want to make sure I got it right. Thank you.
Thanks, Dr. Nari.
Does anyone else want to share a brief story about their involvement in global health, or what gives them? Obviously, everyone who saw this clicked on the link because they're in some way involved or passionate about global health. If you have an interest, you should be able to unmute yourself.
Elizabeth Schley.
Oh, yeah, Elizabeth. Elizabeth, I'm going to unmute you now, and let me know if you can speak.
Hi there, thank you very much. Yeah, I had an incredible experience, albeit very short. I did faculty development in Vietnam. I had the honor to really change medical education. It was done as 2 major flagship medical schools. But I really also experienced firsthand that you have to walk in with an open mind. You cannot assume you go with what you learned in the westernized medicine and westernized education, and you speak the same speech. So you really have to wait until the other person speaks first and shares with you how their culture is.
Yeah, absolutely. And I think that some of the things we're going to be talking about are kind of outside and peripheral of the article, but we're going to be discussing a lot of the kind of the ethical framework that you need to have in order to really responsibly engage in this. And there's some core principles, I think, that are required, and some suspensions of assumptions that are required in order to do this well. And what, it's not, I think the authors alluded to it, but it's not directly in the data, obviously, because there's a bit of a paucity of data, but certainly your point is well taken. We probably have time for one more, or any other stories or comments that people want to have. If you're unable to mute yourself, you can also raise your hand in the participant section, and it'll allow you to. I'll be able to unmute you if you're unable to do it yourself. But you should be able to unmute yourself.
Okay, then
all right. Anya, I'm working on. All right, you should be unmuted.
Hello.
Hi, we got you, Anya. We can hear you. Thank you.
For those of you who don't know me, my name is Anya. I'm a fourth-year medical student as well. I think what Mireille said kind of really resonated with me. I went on a very similar experience and during my undergrad years, and there was a portion where it was medical, and it was great because I got to like see a lot more pathology and be exposed to things I hadn't seen before. But then there was also a component of it where they just like had us helping build a community center. But to be honest, was like, I just remember going throughout the day saying like, I don't know how to build. Like, why are they having like little teenagers build as a part of it? And so I really thought about the ethical dilemma there too. So what she really said resonates with me a lot.
Yeah, it's well taken. I think anytime we're being invited to go someplace, we have to recognize that there's a kind of a responsibility on us because of our level of access as coming from the global north or a high income country, the certain kind of expectation, kind of that question you ask yourself, am I qualified to do what they're asking me to do? And it goes from a teenager being asked to build a school or a library all the way up to a surgery resident that's a PGY 5 surgery resident being asked to do something that's way outside their scope. And certainly that's something that I think happens. Richard Schwartz, I'm going to unmute you as now, so you should be able to speak.
Hi, can you hear me?
Yes.
Okay, so two things. I have participated in Dr. Barrera's mission to Ecuador, where they do surgery for cleft lip and cleft palate, and certainly there are some missions where there is a finite surgical process, such as cataract removal or cleft lip palate, where clearly they're beneficial. And Barrera's process in Ecuador, it's an annual thing where the people come back for follow-up, and clearly that's helpful. I think a big challenge is what do we do for the non-surgical specialties? That would involve more of an educational mission to try to teach people how to do things rather than us do it for them. But I think the key thing is to identify what the need is rather than for us to decide ahead of time what the need is. I can tell you, and Eric, you're familiar with this, my wife and I did a project after Hurricane Maria in Puerto Rico, where we basically, they had no electricity. So we basically came up with 1,000 solar-powered lanterns to give people light so that they could see what they were doing at night. And that was the need. I mean, who would have thought of that ahead of time? So coming up with what the actual needs are and then figuring out whether or not we can provide them, I think is going to be crucial.
Yeah, I totally agree. And I think one of the things that you won't hear a lot of in this article, but I think is very important, is the need to have very strong local partners that can help guide you in that. And sometimes, we have members of our own community that kind of serve as local partners or local liaisons, but having that local connection that can very clearly elucidate the need. I've also found that, having been on both sides of this, that the perceived need is not often or not always the actual immediate need. So 100% agree.
Okay.
All right, so I'm gonna move forward from here and kind of move into just introducing the article. And then Nicholas is gonna serve as discussant and lead the discussion as we move forward. So, sorry, I'm just fighting a technical issue. There we go. So this was the article, the primary article that we asked everyone to read. It's Brain Gains. It's a literature review of medical missions to low and middle income countries. Sorry, I'm trying to move forward from that. So just to give you a brief background on why the authors felt this was an important article to present with all of you. So 40% of the residents and students surveyed, in their background, had a desire to participate in global health experiences during their training. This article was written in 2012, and since then there's been literature on the number of medical students that want to participate, and that number has grown in the literature to about 66%. And so there's this feeling that at least 2/3 of medical students, and the numbers are similar for medical residents, residents in general, have some sort of expectation of participating in what's called a short-term experience in global health, or STEG, during their training or their medical school. There's been a lot of position papers that have been posted and and posited in various specialties literature about the desire or need for increased ethical transparency and accountability in global health. But there hasn't been a whole lot of data presented on medical missions and kind of the impact that they've had or their formatting. And so this article was attempting to answer that question: is what data exists, what literature exists on these short-term missions. All right, so we are going to take another discussion break to just talk about that first statistic of why do people think there is this increased desire to engage in global health. It has been quite marked since kind of the 1950s. You know, you kind of see this growth curve that's pretty positive in terms of people desiring to travel and engage in these medical missions in other communities and engage in global health in a more substantive way. So if you know how to use the raise hand feature, by all means, raise your hand. Otherwise, I'm unmuting people so people can, or I've allowed people to unmute themselves, so you can just go through and unmute yourself. And the second part of that question was, why is there an increase in access to these global health experiences? So in other words, why is the desire gone up, and why are more people also able to engage in these? Why do we think that's going on? All right.
Nick, do you want to say anything on this discussion question?
Maybe people aren't able to unmute themselves. I'm going to unmute everyone just to see if we're having an issue.
Hi, this is Mark Richmond. Can you hear me?
Yes, we can hear you, Mark.
Oh, good. I think there's several reasons. First, why the desire's gone up. Well, we have so much exposure now through various media to the interesting and sometimes unfortunate plights and cultures in the world. And I think that the increase in interest and the increase in actual activities is related to the fairly constant and easy exposure we have to what's happening elsewhere in the world. There's also, of course, great desire to express altruism, I think, beyond the local communities where people are growing up and getting educated. And so as they're being exposed through media to more of the things that are happening in the world, with the ability to transport ourselves fairly quickly and cheaply, they're able to act on that altruism and the broader outlook they now have.
Yeah, absolutely. I think you hit the nail right on the head. So we're more aware because of the interconnectedness of our communities, the access to media that that kind of give us a better vision of what's going on. I think 50 years ago, you're absolutely right. It was harder to know what was going on in your world, and it was also, even if you knew about what was going on in your world, it was harder to get there. And I think from a systems perspective, there's also this increased, because there's an increased desire. And when you see that medical students and residents want this, there's also this desire by hospital administration and medical student administration to meet that need in order to market their school or their residency program. So 100%. Any other comments on this? Everyone should be unmuted at this point and muting themselves. Howard?
Yeah, this is Howard Hyman. I was in the military, and I did some humanitarian missions with the American Army, but and mixed groups. Some of the secondary objectives, though, besides altruistic, were to explore early in your career, to explore some of your choices and to get hands-on experience you might not otherwise get in the United States or similar first world countries. And then the other thing would be, still usually early in your career, you might get exposed to things that you couldn't get exposed to here in terms of advanced disease that might have been caught earlier in a better resourced medical system. So that doesn't seem as altruistic and maybe considered negative, but in some ways it's still positive because you're still doing good by people.
Yeah, and I think that, there is, I still refer to that as medical tourism. And I think that, it has become a dirty word in that programs that are exclusively designed for medical tourism, where there's a clear beneficiary and a clear non-beneficiary, I think that those are very problematic programs. But even in the programs that are very sustainably run and well run, where the host country and the host patients benefit significantly from the interaction, I do think there's still a valuable learning experience to be had by the learners that engage in these experiences and events. And even if it's just not necessarily more advanced disease or opportunities to be more hands-on, but even pathology that they read about in textbooks that are only located where a lot of global South kind of low and middle income countries are. I've still seen more tuberculosis in my 8-week sub-I in Botswana than I've seen in the rest of my medical career. And so, yes, I think there are those experiences to be had, 100%. Other comments?
Nick, do you have anything you want to add or think from the MPH perspective, since you've been in that degree and now you're doing a doctorate of public health?
Okay, can you hear me now?
Yes. We can hear you.
Okay, perfect. I think one of the things that we always consider, I can speak from the public health perspective starting out, is that, our ultimate goal is to serve populations and promote better health within our surrounding communities and globally. So I feel that the way that we are educating our health profession students, including medical students, nursing students, health administration students, and even the health informatics students, is not only just looking at it from I guess a very narrow perspective, as in what's just going on around you personally or even around your immediate community, but looking at it from a population or public health perspective from the get-go, and understanding some of these challenges, both practically and philosophically, that have, I guess, in the past, have just not been considered. And the ease of access or the more readiness for access to this global health, these global health objectives that we now have as part of our education. So I think not only is it the access, but the people who write the curricula are considering this as a necessary objective for education.
Yeah, agreed.
That's interesting. Okay.
Right. I'm going to move on, yeah.
We'll have more discussion coming up.
Yes. Yeah, so just to take you through the methodology, this was a review of the literature of the Medline indexed literature. They used a Prisma format for the medical review, and they present it as a systematic review. But Wendy's going to go through and in a few minutes and tell us why it wasn't a systematic review. But they presented it as a systematic review of the literature. They looked at 25 years of literature. So they looked from August 1985 to December 2009. They reviewed just titles, and then if the abstracts were available, if the titles had a positive, they would then move to abstract or the full text, depending on whether the article had an abstract. And they were looking strictly at medical missions, which they're going to define in a minute, but it's English literature and high-income countries sending providers to low and middle-income countries. They excluded anything that was disaster or emergency response or any military work, and they also excluded anything that wasn't clinical work. So education training programs that were published in the literature, it had to have included clinical work. So if there was no clinical work described, it was excluded. They looked at descriptive data when they narrowed down their articles. Yeah, they looked at the descriptive data. So they looked at the author, the year, the journal, and the methodology in the journal. They looked at the mission details. So basically, they classified it as either exchange, short, medium, or long term, which I'll go over in a second what those distinctions were. They looked at organizations and countries involved, funding source and history of the collaboration of the funding source, and then the health professional type, who was engaged, the type of care that was provided, and the typical type of disease that was treated. And they went over, they also included whether there were any education or training aspects of the article were included. So the limitations of the methodology, so there, or Wendy, are you doing this part?
Wendy, why don't you?
Sure, yes, I can go over the methodology. Can you
Sure.
hear me?
Yes, please.
Perfect.
Great, wonderful. So hi, everyone. So there were several limitations of this methodology. One of them, which actually isn't listed here, is it was very much resembling a systematic review, and but this literature review was not a systematic review. One of the big factors that one would determine if it was a systematic review or not was whether they searched for more than one database. And in this case, they only looked at Medline indexed articles, although their process of synthesizing the information and extracting the data was very systematic. Other limitations for this particular study, the authors had indicated that there's no uniform term for short-term medical missions. If you look at PubMed, for example, there actually is a mesh term called medical missions, and they specifically indicate that it's only looking at short-term medical missions. But I think the authors have a point that, you know, medical missions may be described differently in different words, some of them being foreign missions, humanitarian missions, etc. So they had a difficult time feeling 100% confident that they were capturing all the ways in which a medical mission may be described in the literature. Other limitations, it was limited to English-only articles, and it also didn't include long-term medical care, so that includes any medical missions that exceeded over 2 years. Some of these things were already talked about in the methodology section, but there were a lot of exclusion criteria in terms of what articles were not included in the study, some of them being because the study didn't look at direct clinical care, if it's military sponsored, et cetera. And all that information can actually be found in the supplemental information. Let's see, so gray literature was not included, and when I say gray literature, I'm referring to anything that's not published in a journal. So anything in terms of conference abstracts, conference presentations, all those are not included. And so that's inherently, there will be some sort of publication bias if you exclude that type of literature. Also, I can imagine that there's actually a wealth of knowledge in perhaps the unpublished literature on some of these topics, which is really unfortunate that they decided not to include the gray literature. And then finally, the authors didn't indicate this under their limitations, but one of the bigger limitations I felt just by reading the methodology alone is the fact that they decided to exclude articles that were not available through the university. I believe somewhere in the methodology it indicated that they eliminated over 100 articles simply because they didn't have access to them, which is also something that can easily be remedied through interlibrary loaning or what have you. And so I felt that that was a very, very large limitation for the study.
Yeah, that sounds quite large and unusual, actually, right, Wendy?
Right. So I feel like, you know, if it's, let's say 10 or something, you know, relatively low, then you might be able to excuse it. But eliminating, I think, over 140 something or other was really big in my mind when I was reading the methods section.
I just want to ask you a quick question, Wendy. The PRISM format they use is standard for systematic and scoping reviews, or just systematic? They mentioned the PRISM. Can you just define what that means for the group?
Sure. So the PRISMA framework, I mean, I'm sure everyone has seen an iteration of it, but essentially it's that flow chart that you see whenever you're reading a systematic review that indicates this is the number of article databases we searched, this is how many that we retrieved, and then if you go down the tree, it eliminates the numbers that were excluded at every phase of the study. It's typically used for systematic reviews, meta-analyses, and scoping reviews where you're dealing with multiple databases and multiple citations and multiple stages of screening.
Gotcha. Okay, thank you.
You're welcome.
Great, thank you, yeah. Well, said it better than I could have, certainly. This actually is the PRISMA, I think, then Wendy, this would be classified as the PRISMA flowchart, right, for this article?
Yeah, it's actually a bit more detailed than what I'm typically viewing, but it's essentially the same thing. So yes, it's a flow chart that tells you, how many you started off with and how many you ended with.
Yeah.
So they ended with
230.
right.
Yeah.
200.
Yeah, and just adding up that step 3 to step 4, that I found that to be striking too. So the article not found is about 400 articles that were not found.
Right.
With a total N that they finally got to was 230. So that means eliminating, when you started with 800 at step 2, and then you eliminate 400 with just not being available in your library, seems like a pretty large limitation. That was my one kind of big limitation for this study.
And I just want to say, I think for everybody on the line, part of the reason we do Journal Club is, yes, to understand med ed, but it's also this type of article you think you might use as evidence for something because it's a systematic review. And believe me, I've used systematic reviews in work that I've done, but you have to understand the intricacies of doing a systematic review. And luckily to Wendy, I learned the difference with a scoping review, which is there's a difference. And I think these things are important for us as academics within, Northwell and outside of Northwell. So thanks, Wendy.
You're welcome. And I'm actually rereading the selection part, and you're right, they did indicate they discarded 411. Initially I said 100 something, but it's actually much larger than that.
Yeah, and the results are here. I'm going to read them briefly just because there are people on the phone that don't have the benefit of this. I normally don't read my slides, but this is a different format. So 9% of the articles were eventually picked. So of the 2,512 that they reviewed, 230 were selected as meeting criteria, but the 411 were excluded as not available. Just to give you an idea of kind of what the articles described, 3/4 or 74% were short trips, and they defined short trips as 1 day to 4 week trips. So these are trips that and the variance was basically there were some 1 day trips and then up to 4 weeks. 13% were 5 weeks to 6 month trips, which they described as intermediate length trips, and then 13% were 7 months to 2 year trips, which are kind of long-term mission trips. Only 5% of the articles had any theoretical or conceptual analysis presented. 78% of the articles reviewed were purely descriptive, and then the remainder of that fraction had some analysis, but not a clear theory or concept that they were adding. They presented some numbers or some data. The primary sending countries were the U.S., the United Kingdom, Canada, and Australia. The most visited country in the study was Honduras, and the most visited geography was Sub-Saharan Africa in the study. And just to give you a better visual look at the geography, so clearly Sub-Saharan Africa and Africa in general was an outlier, but Central America, Asia, South America closely behind. And a lot of this is geography. A lot of this is also former colonial relationships. So there's a lot of kind of things that play into kind of what the geography is. It's discussed very briefly in the article, but a lot of these pairings, as you imagine, the country that sent the most number of people to Honduras was the United States because it's geographically very close, and there's also a kind of a bilateral history that exists. Papua New Guinea was also very, very high on the list because Australia has a very close relationship with Papua New Guinea, and so as you'd imagine, there are these geographical pairs that existed in the article. The top 5 health issues are listed here. So the ones that were described, cleft lip and cleft palate were almost 1/4 of the articles that described a health issue. The other health issues that were described were oral and dental health, vaginal fistula, congenital heart disease, and cardiovascular disease. And there were an enormous number of articles where there was no primary health issue described. It was the mission involved going and responding to the immediate needs, presenting in kind of an acute care format to the members that presented to the healthcare providers that were present. So not very well defined in literature. Just we went there, we saw patients, and we did some stuff.
Right.
next, this goes over the kind of journals that they presented to. And like I said, these were mostly descriptive or responsive. Yeah, I'm gonna make this smaller so I don't have to see myself. There we go. So there was an enormous kind of range of journals. The highest numbers being general medical and surgical journals, nursing journals. Other was next, and not surprisingly, one of the lowest on this list was public health. And I think that's because I think these types of articles, descriptive reviews, in all honesty, probably even in the early parts of this, don't pass muster for public health journals. I mean, presenting a descriptive article with not a lot of data, even in 1985, was just not an exciting thing for the public health literature. And so it just gives you a sense of kind of what kind of journals were receiving this and publishing it. And I think it was partially because there was just a paucity of even descriptive pieces in these journals prior to that.
I think it's interesting, though, that emergency medicine has so little, because you think that it's such a big aspect of emergency care.
Yeah.
That it was so low.
Part of this, I think, maybe because one of the exclusions was an emergency, any type of response to a disaster.
Right.
So I think you probably had that not been excluded. I mean, someone who has published data on emergency care, a lot of it is focused around disaster or complex humanitarian emergencies. And so that was an exclusion. I think that probably was underrepresented. What wasn't included pretty much universally across all of the journals presented is the funding sources, and then in that, kind of wrapped into that, the potential biases with funding, and who really was involved in collaboration. The sending and receiving organizations, their institutional history wasn't universally presented, and there was no discussion in the articles surveyed. There was no discussion of or articles reviewed, excuse me, of the standards, policies, ethical considerations, or evaluations. There were one-off discussions about, I think they quoted in the article, they quoted a surgeon saying, well, I wonder if we had just taken the $30,000 that it cost to bring our team here and just given it to our local partners, whether more good would have been done. And so there was kind of the initial kind of anecdotal descriptions of ethical issues, but no robust discussion in the articles. The discussion basically went over the potential benefits and drawbacks. So I'm just going to briefly give a synopsis of these. I'll read the slides for people, and then we're going to go into a discussion about it. But basically, the authors of the review felt that the exposure of medical teams to different cultures and systems had intrinsic value for both the recipient cultures and the learners or the members of the team from the high-income country. Individual level care was described as, quote, very helpful. So, and especially when you're describing kind of going in and fixing cleft lips or cleft palates, and you've got a before and after photo, there obviously are these individual cases where there is a huge impact in that person's individual life. The additional example for this was the training component, being able to take general surgeons that aren't equipped in the local community to fix cleft palates and provide kind of peer-to-peer information exchange and training so that they're able to fix cleft palates after the team is left, was a big example of kind of the training component for these trips. And the other thing that was mentioned was that it puts a, quote, human face on the challenges to healthcare delivery in low and middle income countries. And there was a quote in the literature that was of a participant in one of these missions saying, I knew there was poverty in X country, but I didn't realize how or what that looked like, what the human toll of that poverty or lack of medical access would look like. And it was, despite thinking that they were prepared for a trip like this, they were still invariably shocked at kind of the level of need. The critiques on this, which definitely outnumbered the benefits, were that this isn't really a sustainable model that's presented in the literature. There were some other anecdotal descriptions of this is a Band-Aid on a gaping wound, described by one of the participants that wrote this article in. in general, they said there's a paucity of follow-up data, poor relations with their local healthcare system, and a lack of sustainability that can challenge good intentions. So the idea that intentions are not enough, that intentions are important, but that kind of doing the groundwork to make sure that those intentions are realized is vital to the program's success. The cost effectiveness really wasn't discussed at all, and there wasn't even a way to measure it because no costs were discussed in the literature that was reviewed. And there was this other kind of discussion about balancing or contending with the fact that a lot of these trips seem to be based on surgical tourism, medical tourism, and practicing outside of your scope or capability in a way that you would not be able to in the United States. Or in the sending countries, not just the United States, but the UK, Australia, and as well. And that it was not multidisciplinary or collaborative. So that we're not talking about multiple different teams involved, and we're not talking about a lot of collaboration. And I think kind of hidden in that is the follow-up piece to this, is that a lot of these were fly-in and fly-out missions without not a lot of preparation nor follow-up on either end. And so the officers had several recommendations. They obviously feel like there needs to be more data. Like every good article published in the literature, they say further study is required. But they have a real point here. There isn't a lot of measurements of any long-term impact data. And they queried basically, is there local integration for follow-up and referral that's done in these programs? Is it successfully done? And if it isn't, are the people who engage in these medical missions ethically obliged to follow up? So if you're going to a country and you're operating on a patient, is it now your ethical duty and responsibility to make sure that that follow-up is arranged or coordinated? They wondered about the impacts of the profession and students in both the sending and receiving countries. So in some ways, these missions disrupt the local healthcare infrastructure. So you're coming in, you're providing a service for free, and maybe the service existed, but physicians were charging for it. And they're going to now go to the mission, get their cleft palate done, and now the local ear, nose, and throat or plastic surgeon is now out of a job because these are not being coordinated with local partners. And then the effect on the local healthcare environment. How do you work with the public infrastructure, the local resources that exist to make sure that you are not just completely displacing them, but involving them? And this really gets particularly hairy outside of that surgical model when you're screening or dealing with medical patients, right? I always joke with the medical students, you got to vet your organizations you're going with, because providing a month of metformin to a diabetic, like, what's the plan? After the metformin wears off, like, what is your follow-up plan? And the answer is probably you shouldn't be providing metformin. You should be providing a service that integrates with the local healthcare environment and allows you to kind of connect those patients to true longitudinal care, especially for problems that are ongoing. And so their conclusion statement and their summary was that they encourage mission organizers and participants to have a more precise approach to mission planning, implementation, and reporting. And this is something that I think really grabs at the heart of it, is that a lot of this is not the 2-week trip or the 1-month trip. A lot of this is the months and months and months that leads up to a trip like this, and the months and months and months that follows it, to make sure that there truly is an impact and that there's a mutually beneficial relationship for both parties, both the sending country and the receiving country. So I'm going to turn it over to Nicholas to lead the discussion.
Thank you. Can you guys hear me?
Yes, we can.
Okay, perfect. So I think one of the things that we have going for us here is a lot of opportunities to really assess what are the benefits, what are the opportunities, what are the social, communal or social justice concerns of how are we building infrastructure. So one of the things that was kind of outlined in the article, if I can just remember exactly where it was that the medical missions often treat rather than prevent. And this is a very interesting point to make because, it's within, I heard it on Friday during the white coat ceremony, during the Hippocratic Oath. Prevention is preferable to cure. And we are a very reactive kind of, environment for healthcare rather than proactive. So to kind of give a little bit of a framework for how we can consider this is we have to consider what is our, as Eric kind of pointed out, what is our duty to these people as the host country to these people. And what are the beneficence, as in the do good, or the non-maleficence concerns, which is to prevent harm, in providing these quote unquote temporary or band-aid services when maybe the follow-up is not as robust as it would be, say, here in the United States or in other high-income countries. So I wouldn't mind hearing from some of the folks who are on the line, what are our ethical obligations to the global community when it comes to these reactive ways of treatment?
And participants, you definitely should be able to unmute yourself now. I fixed the technical glitch, so if you go to unmute me, it will unmute you and you'll be able to speak.
This is an important question because we're very early in our career in global health, centralized here with Eric at the helm.
So I'm gonna, since somebody else is speaking, I'll jump in as somebody who's an observer of this and just, not a medical professional. Microbiology is my thing, and so I obviously follow public health and global medicine. But it seems to me that until we sort the reasons for why these medical missions, or whatever you want to call them, happen, until we sort of shift from the I'm going to meet some of my needs to I'm going to go meet the needs of the country I'm going to we're not going to there's not going to be a lot of progress. And I think you can look at models like Paul Farmer's work in Haiti, where he's, where they've spent a lot of time and money and resources training local healthcare workers. You can look at successful, just even look at like the smallpox elimination and how many local people on the ground were trained, or the polio, disseminating polio vaccines. That's all done almost exclusively by local people. So until people sort of let go of what am I going to get out of it, to being more altruistic about creating a sustainable, to Nick's point, preventative care, as well as, if you just go in and treat the emergencies, it's never going to go away. It's a, kind of a whack-a-mole kind of approach to public health. So, but I don't know, those of you who are much more engaged in this, is there, where's the leadership? It seems like it's very decentralized. There's all these NGOs, many health systems have their own programs. There's UNICEF, there's WHO, there's other, UN run agencies, but it doesn't seem like there's, to me, from the outside looking in, it just seems like it's all very decentralized and everybody's kind of doing their own thing, which means if you're somebody living in one of these resource poor countries, you're really just waiting to be lucky and have somebody decide that your corner of the world is where they want to show up and do their thing. So I don't know if this is helpful, but nobody else was talking, so I thought I'd throw that in.
Joe, you're always helpful. Premise it with that. I appreciate it.
Dr. Willie, this is Mireille, by the way. I actually agree with you, and what I was thinking before you spoke was, again, like, where does the responsibility of kind of coordinating all this lie? I think having these missions, or just like global health in general requires an understanding of the like healthcare operations and systems in the various countries that people go to deliver such care. And the problem is a lot of these countries don't have as robust of an infrastructure as the resource rich countries do. So but it's a challenge because some governments may or may not necessarily be equipped to or be in such a place to communicate with or develop those partnerships that we need in order to create create a system that's sort of more sustainable and actually delve out medical care in a way that actually has those long-term effects that we want.
So this may be a little bit tangential, but it may be, I think it's something interesting to think about. So I was reading an article about the DRC has this Ebola epidemic going. It's been going on for quite a while. And you're probably aware that it's been very difficult to get it under control despite the presence of 2 very good vaccines. And the article that I was reading, which was in the Times a couple of weeks ago, they were interviewing some people on the ground and they were saying, look, where were all these NGOs? Why do people only care when it's Ebola? How come nobody was here when militias were coming in and slaughtering us? How come nobody cared when it was malaria? Why did nobody care, when our crops failed and we were starving to death? Why is it only when it's malaria do these people show up? And, in the particular article that I was reading, this one community they literally put barricades around their town to keep the NGOs out. And and if somebody died of Ebola, and if the Ebola epidemic took off in their community, so be it. They didn't want the NGOs in there. They didn't want the help. So obviously this is frustrating from the point of view of the World Health Organization, people trying to get the Ebola epidemic under control. But from the point of view of the people who are living in these communities, you can sort of see their point. Like, why is it that it's, doesn't this have to be part of a larger strategy to defeat poverty and promote social justice, not just, we're going to go in and give you bed nets? I don't know.
Yeah, I think.
Sorry.
No.
I think you're absolutely right. And I think one of the things that, just to piggyback off of that we've learned from West African Ebola, Liberia, Guinea, and Sierra Leone, is that creating a more robust infrastructure, would have prevented thousands of deaths and the spread and the security concerns. So this idea that these horizontal programs don't work, right? They don't work well when you just go in and you're like, all you're focused on is laser focused on malaria or laser focused on HIV. And so, creating kind of programs that are a little bit more horizontal, collaborative, ideally those are the programs that would really have the overall greatest success. They also happen to be the most time intensive and resource intensive programs, right?
Yes, but I think they also require some leadership from within, from the country.
Absolutely.
So if you look at the HIV epidemic in Uganda, I think it was in Uganda, the local government, was just 2 or 3 physicians in the Ministry of Health who just took this on and confronted it very early. And they were going out to bars and they pushed it. But the point is, it was coming from within, not from without. And I think, it's all well and good and to go and do these projects, but I think that we're kidding ourselves if we think that we can exist in this little cocoon of helicoptering in, dropping our goodness, in a 35-mile radius, and then helicoptering out. Whose need are we serving here?
So, I think, Joe, this conversation is making me think, like, how, in terms of preparing learners to go, and I know Eric is very focused on preparing learners to go, but more important, the debriefing when they come back, to have these rich discussions about things that we did well and things we could have done better. And I think that whole idea of bookending, preparing people, but when they come back, where sort of you get back into your daily routine with all your resources and all your equipment, and you sort of move on, that debriefing when they come back will make a difference for future work with others, as well as the work they might continue to do. So I think it's showing us the importance educationally, since this is a med-ed journal club, of the importance of conversation beyond the experience itself. When you're there, you're experiencing, which is experiential learning, which is why it's so powerful. But we need these bookends very strongly, and I think the return bookend is the one where we sort of don't do as much, because we can make preparation mandatory and people go, but coming back. So I think that has to be a goal, and I'm so excited that we had a few students on here today, because I think students always lead the way for us, and I hope residents as well, and can make things happen that will improve this as we go forward. I just want to go to the next slide quickly, just to give Wendy, are you here? Just close that up so I don't see that. This is, you want to just mention?
Oh yeah,
this?
I'll just mention, if you haven't heard of the Paris Declaration, I think it's a very good framework. They mentioned it's very old now, in 2005, and it goes over kind of how to making aid accountable and making it effective. But I'm going to skip over that in the interest of time. And then these are two other articles. One of them was actually attached and included in your packet. I highly recommend. So the Annals of Internal Medicine has a core framework for global health that they propose. And then the AMA Journal of Ethics in September of this year just released an entire issue on ethics and global health. So those are two hot off the press resources that I think you should read if you haven't done so.
And Wendy, did you want to go? Did you have a bibliometric slide?
Yeah, it's towards the end of the PowerPoint deck.
There you go.
Quickly.
Okay, there we go. So I'll quickly go over the bibliometrics. I'll be reviewing Scopus as one of the platforms in Altmetric. For the Scopus bibliometrics, since this article was published in 2012, there has been significant citations back to the article. If you see on the screen, there are a total of 88 citations currently captured by Scopus. Not only that, but if you look at the trending line, it seems pretty consistent, at least from 2015 to 2019. And also, if you look at the usage in the middle of the screen, there have been significant numbers of users who've at least looked at the abstract views or have looked at the full text reviews, which are almost in the high 390s. There are 108 Mendeley readers that have saved this article to their library, which is a positive statistic. The likelihood of someone citing this article back is higher for those who use Mendeley and have added this particular article to their library. If you can scroll forward just one slide, please. Thank you. The altmetric count is relatively high. If you see the text box on the middle of the screen, there have been 56 tweets from 37 users, and those 37 users have an upper bound of over 174,000 followers. So it means that this article has been, those tweets have been exposed to potentially those followers. Once again, the Mendeley statistic is very significant. There are 108 Mendeley readers who've saved this. And there are also 96 dimension citations, and I'm looking at the statistics on the left-hand side here. Dimensions is another way of tracking how many cite backs you've had to this originating article, and so there's been a significant number there. And if you have a moment, take a look at the geographic breakdown of who's accessing this article from where. Thank you.
That geographic breakdown is quite interesting.
It is.
Yeah. Total exclusion of an area of the world. Thanks. We're close to the end, and we have contact information, of course, to continue conversation with Eric, Daniel, and Shari Jardine, who works also within our office. And it would be great to have continued conversation, especially with the students who show interest in this. And the last slide, just out of time, because we have 1 minute left and I want to be courteous, is that please, you'll get this slide deck, the hyperlink for the SurveyMonkey, to give us some feedback. Of course, indicate if you'd like to do a journal club or a topic you'd like covered. And we have our next one on November 13th. One of our people who participated today will be doing that journal club, Elizabeth Schlegel, and we're going to talk about coaching as a way to do faculty development. So the concept of using coaching versus, non-coaching techniques. Coaching is a big word in the med ed world today, as well as the business world. So I look forward to that presentation. Today was really exciting for me. Ever since Eric came here, I've wanted him to do a journal club, so I want to thank him. And Wendy, of course, always, and Nick for chiming in. Any last words from Eric and Nick at all?
The only thing I'll say is thank you all for being here. I'm excited. Northwell is really getting serious about creating a Center for Global Health. And the great thing about it is it's still in its infancy, and it really is your center. So I definitely want to hear from you. global@northwell.edu is our catch-all email address. And one of the things we're looking at that I kind of skipped over during the presentation, but we'll send the slides out, is the idea that we need to be very purposeful about this. We need to be very collaborative about this. We need to work with local partners, and that we need to really create these core sites, this idea of a core site where we're going to be horizontally integrating specialties, be collaborative, interdisciplinary, privilege the viewpoint of the people that are doing this work on the ground, and address their needs, and make sure that primarily we are benefiting our hosts, and secondarily, we are creating an experience for our learners that is valuable. And so for the students involved, all the way up through the senior faculty that are on the call, thank you for being here. Please weigh in with me offline on what you'd like a Center for Global Health to do for Northwell and for your experience.
Okay, everybody have a great afternoon, and see you next month. Bye-bye.
Bye.
Okay, we have to capture this and send it to, it's on your computer. Ask Cece how we send this to Wendy. Wendy does the edit.